Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very, very handy in your line of duty. I welcome you all to part 127 of our Pharmacotherapy MCQ series, majoring in infectious diseases. Welcome. And the first question reads, Mrs. T.M.C, a 25-year-old female patient who was diagnosed with chlamydia, presents to your hospital for a follow-up visit after treatment with a gram of azithromycin administered orally as a start dose. And that was 90 days ago. She informs you she's sexually active with a boyfriend and she currently takes oral contraceptives. And she further informs you they don't regularly use condoms during their sexual intercourse. Labs are done and the vaginal lab swab turns out to be N positive. They actually did an NAAT and it turned positive for C. trachomatis. So my question to you is, which of the following would be the next best course of action in this clinical scenario of Madam T.M.C? Would you opt to obtain a culture with susceptibility testing of vaginal swab and administer doxycycline at a dose of 100 milligrams orally twice daily for 2 weeks? Or would you simply administer 100 milligrams of doxycycline twice daily for 2 weeks? Or would you administer another azithromycin 1 gram orally as a start dose? Or would you consider culture and susceptibility testing of the vaginal swab and await results before taking the next action? I'll give you 10 seconds to choose the correct answer. C, in my opinion, is the correct answer. I would choose to administer a gram of azithromycin orally as a start dose to this particular lady. D, in my opinion, is incorrect because it has been 3 months since the previous test, and that makes it unlikely for a false positive to happen. It is usually seen within 1 to 3 weeks after treatment. Then answers B and A are incorrect due to the duration of doxycycline. And apart from that, A also includes incorrectly recommending getting cultures. I would just like to add that a probable infection may have occurred here. And that is what makes sense when you re-administer a start dose of azithromycin. Let's move to the next question, please. And it reads, why is it rational to treat uncomplicated gonorrhea using a dual ceftriaxone azithromycin therapy? Is it because many treatment failures have been documented with the use of ceftriaxone alone? Or is it because dual therapy decreases the selection of resistant Neisseria gonorrhea strains and is effective for treating C. trachomatis infection? Or is it C? A larger percentage of Neisseria gonorrhea strains are resistant to azithromycin? Or is it D, because a large percentage of Neisseria gonorrhea strains are resistant to ceftriaxone? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Dual therapy decreases the selection of resistant Neisseria gonorrhea strains and is also effective for treating C. trachomatis infection. I'd like to add that the dual coverage is recommended with the aim of decreasing selection of resistant Neisseria gonorrhea strains and is also effective in treating C. trachomatis infection. Now, we are not currently seeing large numbers of ceftriaxone resistant strains, although some have been detected. It still remains rare, so that makes answer D incorrect. Then I would like to add that additionally, there is not a large percentage of azithromycin resistant strains, which makes answer C incorrect as well. Then I would like to add that treatment failures are not common for uncomplicated gonorrhea if using the recommended first-line regimen. So that makes answer A incorrect as well. I would settle for B. Let's move to the next question, please. And it reads, Miss L.D.M., a 24-year-old sexually active female university student, presents to your accident and emergency department. She complains of cramping, lower abdominal pain, vaginal discharge, and she experiences dysuria. A pregnancy test is done and it turns negative. Urine culture is also done. Vaginal swab is sent for C. trachomatis and Neisseria gonorrhea, NAAT. And then the emergency department medicine consultant on call appropriately treats Madam LDM for gonorrhea. So my question to you is, which of the following would be the most appropriate follow-up and education in Mrs. LDM's case? Would it be A, serologies for syphilis should be done, and in addition to testing for HIV, and she needs to abstain from sexual contact during treatment? Or would it be B, testing for HIV is recommended with serology for syphilis only if the patient has symptoms, and she should abstain from sexual contact during treatment? Or would it be C, serologies for syphilis should be done, and in addition to testing for HIV, and she should abstain from sexual contact for at least 7 days after completing treatment? Or would it be D, testing for HIV and syphilis are not necessary, she should abstain from sexual contact for at least 7 days after completion of her treatment? I'll give you 10 seconds to choose the correct answer. I would settle for C. Serologies for syphilis should be done in addition to testing for HIV. And this lady should abstain from sexual contact for at least 7 days after completing her treatment. I would like to just begin by commenting that answer C is the correct answer choice, since it includes the most appropriate recommendations for screening for other STDs upon the diagnosis of gonorrhea. Additionally, answers B and A have incorrect information about patient education, abstaining from sexual contact, during treatment. Remember, abstaining should continue until at least 7 days after treatment. Remember that. Now, answer D does not include the correct STD screening recommendation. Therefore, in my opinion, it is wrong. I would settle for C. Let's move to the next question, please. And it reads, Mrs. J.K.W, a 25-year-old female patient, presents to her primary gynecologist at your hospital for the first time during her 3rd trimester. She is pregnant. She comes complaining of mild nausea in the morning. She is sexually active with her spouse, with whom she doesn't regularly use condoms. So my question to you is, which of the statements listed below most accurately outlines the CDC recommendation or recommended screening for this patient, Madam J.K.W.? Is it A, NAAT on vaginal swab for chlamydia and gonorrhea plus serology testing for syphilis and herpes simplex virus type 2? Or is it B, culture on vaginal swab for chlamydia and NAAT on urine for gonorrhea and syphilis? Or is it NAAT on vaginal swab for chlamydia, gonorrhea and syphilis? Or would it be D, NAAT on vaginal swab for chlamydia and gonorrhea plus serology testing for syphilis alone? I'll give you 10 seconds to choose the correct answer. D is the correct answer. NNAT on vaginal swab for chlamydia and gonorrhea plus serology testing for syphilis alone. Now, this answer is the first-line recommendation for screening at the first prenatal visit, and just like to add that the NAAT is not done on syphilis. Remember, cultures are not normally done for screening for chlamydia. That makes answer B incorrect. However, a culture for test of cure would be recommended if this patient was diagnosed with chlamydia during her pregnancy. And I would like to add that HSV serologies are not recommended for screening, so answer A is incorrect as well. That would make me settle for D as the correct answer. Let's move to the next question, please. And it reads, Mr. T.W.A, a 38-year-old sexually active male who has sex with other men, presents to your accident and emergency department complaining of a diffuse rash which has persisted for 42 days after an episode of unprotected sexual intercourse with his new male sexual partner. A syphilis test is done and it's positive. There is a positive VDRL test of 1 to 128. So a diagnosis of secondary syphilis is made in this particular case, and you establish that TWA has no known drug or food allergies. So my question to you is, which of the courses of action listed below would be the most appropriate in Mr. TWA's case now? Would you opt to administer 2.4 mega units of benzathine penicillin G IM as a start dose alongside a start dose of 1 gram of azithromycin administered orally, or would you administer 7.2 mega units of benzathine penicillin G total administered as 3 doses of 2.4 IM at 1 weekly intervals, or would you give 2.4 mega units of benzathine penicillin IM as a start dose, or would you take culture and gram stains of urethral swab to send for antimicrobial susceptibility testing before treating with any medication? I'll give you 10 seconds to choose the correct answer. I would opt to administer 2.4 mega units of benzathine penicillin G via the intramuscular route as a start dose. Now, this answer is the recommended regimen for secondary syphilis, which is what is described in this particular case. The recommendation for 3 doses, which is answer B above, is incorrect in this particular case due to its not being late latent syphilis. I don't think this is latent syphilis, since this patient has symptoms and the RPR from 6 months ago was negative. Now, I'd like to add that answer A is incorrect because it includes a presumptive treatment for chlamydia, which is not recommended in this particular case. Let's move to the next question, please. And it reads, Mrs. ZPL, a 27-year-old female patient, undergoes testing for STD at your antenatal clinic during a visit in her first trimester of pregnancy, and the results are an RPR of 1 to 128 with the FTA-ABS reactive. And you establish that she has a penicillin allergy and she had anaphylaxis during childhood when she received a penicillin. So my question to you is, which of the management strategies listed below would be the most appropriate in this clinical scenario of Mrs. ZPL? Would you administer 100 milligrams of doxycycline orally twice daily for 2 weeks? Or would you administer 2 grams of azithromycin orally as a start dose? Or would you begin penicillin desensitization protocol without penicillin skin testing to confirm allergy? Or would you confirm allergy with penicillin skin testing and, if positive, begin penicillin desensitization protocol? I'll give you 10 seconds to choose the correct answer. I would settle for D. I would choose to confirm allergy with penicillin skin testing, and if it emerges positive, I would go ahead and begin penicillin desensitization protocol. Now, I'd like to begin by saying that skin test is needed for confirmation of true allergy before you embark on desensitization of any patient. And penicillin is a drug of choice for the treatment of syphilis, especially in pregnant women like this particular patient. I would like to add that answer B would not be appropriate due to lack of efficacy, and this is not recommended for use to treat syphilis in pregnancy. I would not go for 2 grams of azithromycin. Then I would like to add that answer A is incorrect because doxycycline, a tetracycline, is not recommended during pregnancy. I would not dare. And I would like to add that answer C is incorrect since it lacks confirmation of the patient's allergy prior to doing a desensitization protocol. So D, in my opinion, would be the best bet. Let's move to the next question, please. And it reads, Mrs. J.O.Z., a sexually active 26-year-old female patient, presents to your accident and emergency, complaining of cramping, abdominal pain, and dysuria. Her urine pregnancy test turns out negative. On physical examination, the physician notices uterine tenderness and cervical motion pain is established. And Madam J.O.Z. is ill appearing, according to the physician examining her. Some of her pertinent vitals include temperature of 38.6 degrees centigrade, CBC significant for leukocytosis, and some of the relevant labs include urinalysis, which with reflex to culture, and a vaginal swab is sent for CT, NG, NAAT, that is C. trachomatis, and Neisseria gonorrhea, NAAT. Those are the tests that are ordered. Now, Mrs. J.O.Z. is admitted to your general medical ward, and empiric treatment for severe pelvic inflammatory disease is initiated. The question to you is, which of the regimens listed below would be the most appropriate for Madam J.O.Z.'s case now? Would you do empiric treatment with azithromycin at a dose of 500 milligrams IV once daily, infused over an hour? Or would you infuse ampicillin sulbactam unacin at a dose of 3 grams, infused every 6 hours, plus 100 milligrams of doxycycline administered orally twice daily? Or would you initiate ceftriaxone 250 milligrams IM as a start dose, plus oral doxycycline at a dose of 100 milligrams twice daily? Or would you go for cefoxitin 2 grams IV infused every 6 hours, plus oral doxycycline at a dose of 100 milligrams administered twice daily? I'll give you 10 seconds to choose the correct answer. D, in my opinion, is the correct answer. I would settle for cefoxitin 2 grams infused every 6 hours and oral doxycycline 100 milligrams administered twice daily. Now, answer C, in my opinion, would be a potential outpatient option in the setting of a mild to moderate infection. However, there is a current debate over the need to add additional anaerobic coverage, since third-generation cephalosporins do not cover anaerobic bacteria such as Prevotella species and other anaerobes which are associated with bacterial vaginosis. And that such bacteria have been detected in women with pelvic inflammatory disease. So answer C would be inadequate. Then answer B, in my opinion, is incorrect, since this is listed as an alternative therapy due to increased resistance in enteric gram-negative bacilli as well as Neisseria gonorrhea. They are getting more and more resistant to unacin, so I would not go there. And answer A appears incorrect to me, as this patient has severe disease and azithromycin lacks activity against some of the enteric gram-negative rods, as well as not being recommended as monotherapy for coverage for Neisseria gonorrhea. So all those many words qualify answer D as the correct bet. Let's move to the next question, please. And it reads, Mrs. QPR, a sexually active 25-year-old female, presents to your accident and emergency complaining of dysuria, cramping, and lower abdominal pain. Urine pregnancy test is done and it turns negative, and you establish she received all her scheduled vaccines till the age of 9 years. All relevant lab tests are ordered, including a UA with reflex to culture and a vaginal swab sent for C. trachomatis and Neisseria gonorrhea NAAT. And the final diagnosis of chlamydia is made. So my question to you is, which of the statements listed below outlines the most appropriate course of action in Mrs. QPR's clinical scenario? Would you ask her to refer all sexual partners in the past year for evaluation and treatment? Or would you administer 250 milligrams of ceftriaxone IM stat and 100 milligrams of doxycycline orally twice daily for 7 days? Or would you offer this lady the HPV vaccination series because she meets the age criteria and was never immunized? Or would you ask this lady to return in 3 weeks after completing treatment for a test of cure? I'll give you 10 seconds to choose the correct answer. C is the correct answer. I would offer this lady the HPV vaccination series because she meets the age criteria and was never immunized at all. Remember, the patient has an indication and meets the criteria for HPV vaccination series as she is currently under the age of 26 years and is sexually active, or recently has been, as demonstrated by a diagnosis of chlamydia. Now, I would like to add that answer D appears incorrect to me, as the recommendation to a culture test of cure after treatment of chlamydia is reserved for pregnant women, and we are told she is not pregnant. The test turned negative, so I would not go there. And then answer B appears incorrect to me, as the addition of ceftriaxone would only be needed if the diagnosis of gonorrhea was made. We are told they diagnosed chlamydia, not gonorrhea, so we would not require that ceftriaxone. That would be an overkill from an AMS point of view. Then answer A, in my opinion, is incorrect, because the most recent sexual partners should be referred, as well as sexual partners within the last 60 days. Let's move to the next question, please. And it reads, Mr. HPL, a 26-year-old male patient, presents to your hospital complaining of recurrent genital herpes, and this is the 5th episode in the last 2 years. So the episodes are annoying, bothersome, and painful to him, and he would like to reduce the duration and severity of the lesions, but isn't willing to take daily prophylactic medication for prolonged periods, since the episodes occur only occasionally. In his own words, Now you establish that 90 days ago, your lab confirmed he is HIV negative and he has no pertinent illnesses, no medical history. Now you also know that previous episodes have been successfully managed using acyclovir. So my question to you is, which of the following prophylactic regimens would you make to HPL to consider for self-administration as soon as the symptoms of genital herpes recurrence occur, with the aim of reducing the duration and severity of genital herpes episodes? Would it be famciclovir 250 milligrams orally twice daily for 10 days, or would it be valacyclovir 500 milligrams orally twice daily for 3 days, or would you settle for valacyclovir 1 gram orally twice daily for 5 days, or would you settle for acyclovir 200 milligrams orally every 5 hours for 7 to 10 days? I'll give you 10 seconds to choose the correct answer. I would recommend treatment with valacyclovir 500 milligrams orally twice daily for 3 days. In my opinion, B is the correct answer. Now, answer D is incorrect, since the duration of 7 to 10 days is for initial episode treatment. And the dose and the frequency are also incorrect. They are not correct for episodic management. Then answer C is incorrect, because the 1 gram dose should be daily for episodic management. Then answer A, in my opinion, is incorrect, as the duration of treatment for episodic management is shorter than the duration for initial herpes infection. Remember that. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. And I thank you all very sincerely for viewing and for listening to this video. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in the next video. Thank you.